Such a pleasure to be here. Thanks for having me, and thank you to Dr. Raman Sharma, excuse me, and Dr. Krishnan for the invitation. It's a great turnout, and I'm hoping to give an overview of CT and MRI in peripheral vascular disease. I teach a lot of the vascular fellows, and so I might be diverting off the path a little bit of what we do at Mount Sinai and what you'll be learning if you sit next to me and start reading CT and MRI on our vascular patients. We can't advance. Okay, I have no disclosures. So just quickly, background about peripheral arterial disease. We know it's the third most common vascular disease, only after that of coronary heart disease and stroke. In 2010, there was 22 million patients with PAD worldwide. It's a manifestation, as we know, of systemic atherosclerotic, usually affecting about 14% of the entire population. And because I'm speaking about CT and MRI today, or MRA, it is the most common advanced imaging modality for diagnosis, disease monitoring, and procedure planning. So we're going to discuss the role of imaging before and after peripheral arterial interventions and how we want you to improve your interventional outcomes for best patient care. So we're going to work alongside with you with imaging to make sure we have the proper diagnosis and great outcomes. As Dr. Kadian had just mentioned, which I will not touch because she did such a spectacular job, are the ABI and TBI imaging modalities, pulse volume recordings, and arterial duplex, as you had just seen. But I'm going to focus on the gold standard, CT angiography and MR angiography. I will not be touching on intravascular ultrasound. So why is CT so great? Well, it really has a great evaluation of the vessel size, the character of the vessel wall, particularly the aorta and its great vessels. Excuse me. It looks really well at the calcification and calcified plaque, as well as non-calcified plaque, wall thickening, especially wall enhancement if there's aortitis. We make quite a few of those diagnoses, and any type of mural thrombus. The treatment planning, excuse me. The treatment planning by identifying the levels of the disease, as well as the amount of calcification. The length of the disease is important to you, pardon me, as well as the presence of an occlusion or subatotal occlusion in the native vessel. And we can look with CT and MR all the way down to the branch common iliacs, femorals, all the way to the bilateral tibial arteries. And why is CT so important? Because it provides excellent diagnostic value for acute limb ischemia, and that's why you're here. I'm going off the grid a little bit because I really want to introduce this paper that was just published by Kosmala et al. About a month ago. And the reason why I want to publish this is that right now we're using digital subtraction angiography, or DSA. And that's been traditionally used, and it's considered right now the gold standard, and it's what we use at Mount Sinai. But it's excellent for pre-treatment evaluation of arterial stenoses in patients with PAD. However, we're looking at something called dual energy technique for CTA, and this actually offers more advanced tissue characterization based on material-dependent X-ray attenuation at different photon energies based on different tissue characteristics. And by simultaneously, and I'm getting a little too detailed, but by simultaneously acquiring different data sets at these low and high voltage tubes, we're able to post-process material based on these algorithms so that we could actually remove bone and calcification and give you a great CTA luminogram. So there would be no doubt if there's a significant stenosis in a large artery. This also permits reconstruction of three-dimensional maximum intensity projection, which actually gives you a little bit more information than the classic DSA, which we're using now. So this is an example from the paper of a 69-year-old male with PAD and underwent two types of CTA. The first type was the digital subtraction seen in A, that we use pretty regularly. And then he underwent a second CT, which is the dual energy CTA. And as you can see here, the dual energy can remove bone as well as calcification. And we made a diagnosis here of the mid-SFA of a moderate focal stenosis. But if you look more closely at the dual energy CTA, it actually is more severe by subtracting the calcific wall and the surrounding bone. And you could really get a good understanding of the surrounding tissue on cross-axis, as well as a beautiful MPR to show you the gradation of stenosis within the artery. It also will give us three-dimensional maximum intensity projections so that we could reconstruct the entire arterial tree and see multiple areas of stenoses. So let's look at PAD, pre-intervention. This is an example, what we use today, of the digital subtraction angiography. And you could see really well that there is, I lost my mouse. You could see really well that there is an obstruction, both calcified and non-calcified plaque, a subtotal occlusion of the right common iliac artery with reconstitution distally. And if you look up close, you could see a really significant non-calcified and calcified stenoses of the profunda and SFA. And we're pretty used to seeing this. It's excellent intervention by our colleagues. It's actually a case that we had just last week or 2 weeks ago. And you could see stent patency, again, with just a simple digital subtraction angiography from the common femoral SFA all the way up to the supraarticular popliteal artery. So let's go off the beaten path a little bit. I'm going to go over the aorta, kind of leave the lower extremities for now, because this is what we do mostly. And when I'm sitting down with the fellows, teaching them CT and how to read aneurysms and dissection, this is where we usually focus. So just bear with me. We know that aortic dissection belongs to a family of acute aortic syndromes. This is not new to you: intramural hematoma, penetrating atherosclerotic aortic ulcer, as well as thoracic aortic rupture. We know that aortic dissection is the most common of these life-threatening aortic conditions. And the incidence is 3 per 1,000 patients that present. We know it results in a tear in the intimal layer of the aorta with consequent splitting of the media, forming both a newly false lumen separated by the true lumen by an intimal flap. It is most common in men over 65 years of age. If we look solely at type B aortic dissection, type A is a whole different category. It usually originates just distal to the left subclavian artery, and it's usually delineated chronologically based on the clinical onset. So we have acute, subacute, and chronic greater than 3 months. The acute complicated type B aortic dissection is defined by the presence of at least one of the following. Aortic rupture, refractory pain, or rapid aortic expansion, uncontrolled hypertension. Most commonly, what we're concerned about is malperfusion of the viscera. Malperfusion syndrome is the most common frequent complication, with an incidence that almost approaches 30% of all cases. Mesenteric compromise carries a high mortality of over 30%. And malperfusion is usually caused by two factors: either a static or dynamic obstruction of the branch vessel arising from the aortic segment that's affected. So if we look at, I'm not going to go over any of the classification. You've known this pretty well. You've all taken or about to take your cardiology boards. But if we break it down to Stanford A or Stanford B, or the DeBakey classification, it's still a type B aortic dissection using the Stanford B. But if you look at the second figure on the right, this figure actually depicts what we just mentioned about the two causes of malperfusion syndrome, both static and dynamic obstruction. Static obstruction, as you can see in A, is the result of any fixed obstruction, and the most common cause is dissection of the branch vessel and then thrombosis of that false lumen. The dynamic obstruction, however, is actually more common in malperfusion syndrome, and it's caused by a branch vessel into the ostium that is intermittently blocked by the dissection flap. So this is an example of a patient of ours here at Mount Sinai with a recent publication by our colleagues. It's a 54-year-old female with a type B aortic dissection that presented with mesenteric ischemia and was found to have a pretty dynamic obstruction of her SMA. And if you look at figure A, it's a great example of an axial view of CT post-contrast. And you could see that the SMA is not filling properly here at the red arrow. When we do a 3D reconstruction using digital subtraction angiography, we could see the dissection extends into the superior mesenteric artery. In C, in the lower CTA post-contrast, you could see that a TVAR, or an endograft replacement, was stented just distal to the left subclavian artery. And by doing so, there's reperfusion of the SMA, and you could see that in D because of repressurization of the true lumen. Well, why do we do this? Well, of course, to save the patient's life, to improve perfusion of the visceral organs, obviously, but we're looking to look for a favorable aortic remodeling in type B aortic dissection. This is a 66-year-old man that also presented to our emergency room, and the CT here on the left shows pretty profound type B aortic dissection with multiple tears. If you look at the second CT post-contrast, the stent grafts were placed through an endovascular aortic repair, and this is 1 month follow-up. You could see favorable aortic remodeling. So TVAR has been around since 1999. It's used, as we mentioned, for complicated type B aortic dissections. Several clinical trials have reported that TVAR actually offers improved all-cause and aortic-specific survival and mortality. It delays disease progression and disease complication associated with type B dissection compared to that of medical treatment alone or open surgical repair. And I'm sure our surgical colleagues don't want to hear that, but TVAR reduces false lumen blood flow, induces false lumen thrombosis, and allows endograft-assisted true lumen expansion, which we're all aiming for. And of course, favorable aortic remodeling, as well as overall aortic diameter stabilization. So this is just an example of a patient that we had last week. You could see a dissection flap here in the lower descending thoracic aorta, as well as multiple areas of aneurysm and calcification, kind of a ratty thoracic aorta. And then immediately post-TVAR, we see a month later some interesting remodeling of the aorta and stabilization of that dissection flap. In one publication recently, again, you just look preoperatively in the proximal descending thoracic aorta with the dissection flap, and then immediately post-TVAR, you could see resolution of that dissection flap with some thrombosis within the stent. But then at 5-year follow-up is complete favorable aortic remodeling. Well, what about abdominal aortic aneurysms? We probably do that more commonly at Mount Sinai recently. Triple A's have been defined as dilatation of greater than 50% of the normal size of the aorta. This is all review for you, or greater than 5.5 centimeters. But in 2015, the CDC ranked triple A's as one of the top 15 causes of mortality in the United States. And as of 2007, 70% of triple A's have been repaired by endovascular techniques. What initially began exclusively as an infrarenal triple A repair has now expanded to pararenal, suprarenal, and thoracoabdominal aneurysms, all with preserving branch vessels. And as this technology improves, we're getting farther and farther away from endovascular leaks, which is extremely important, not only for decreasing sac expansion, but to make sure that there is no mesenteric ischemia. Really quickly, we work with our surgeons, cardiovascular surgeons, CT surgeons, vascular surgeons closely, as well as our vascular lab and the cath lab. And once these devices are deployed, we really want to look for endo leak. There are many different types of endo leak. Most people are just concerned about whether or not endo leak is present. And I think I guess I'm not as good as Danielle. I had one or two more slides, but it's been a pleasure to be here. Thank you.